Okay, everyone, we're going to get started. So we will continue with presentations of the results from some of the abstracts that were selected. Following in this session will be 3 talks from 3 abstracts that were selected for oral presentations. So I'm Kevin Saunders. I'm a 2014 CFAR recruit, also a graduate from a CFAR laboratory for my PhD. Currently the director of protein expression and DHVI. I have the pleasure of introducing Dr. Dorothy Tabb. She will be coming forth to talk about the association of self-reported adherence and antiviral drug concentrations in hair among youth with virologic failure in Tanzania. Dr. Tabb.
All right, thanks so much for having me present. Sorry, I think I started losing my voice by talking so much during posters, but I'm here to present on behalf of Zachary Tabb, who was our wonderful medical student last year. And like Nathan's project, this is funded by Fogarty, but it all comes from seed money from a small grant I got back in 2013, 2014, which without that money, I don't think I would be here with all of the great work that's come. So thank you to CFAR and for all of the contributors to this work. So just to give you a sense, I think many of you have actually been to Moshi, but this work took place in Moshi, Tanzania, which is right on the Kenyan border by Mount Kilimanjaro, and it's a beautiful place to work. And I just want to couch this discussion in, why does this work matter? Some people don't realize, but AIDS is the #1 cause of death among adolescents in Africa. And it's the second leading cause of death among adolescents around the world. And we know how to diagnose HIV, and we know how to treat HIV, so why is this the #1 killer of youth? Adolescent deaths have tripled since the year 2000. When you look at other age groups, mortality is actually reduced. So this question's really bothered me, and I see it every day in clinic. And we know that worldwide adolescents have real difficulty adhering to their antiretroviral therapy. Their virologic outcomes are worse when you compare them to children or to adults. And they have a much increased risk of transmitting a resistant virus. These kids are becoming sexually active, intermittently adherent, and it's a real public health emergency. The way that we usually estimate adherence is by self-report. So it's cheap and easy. Youth comes to clinic, you say, hi, Susie, are you taking your medicine? They say, yes, I am, doctor. You say, great. Here's your medicine, keep up the good work, and on we go. But we know that this leads to over-reporting and social desirability bias. And it leads to some real clinical dilemmas because fortunately in Tanzania now we have the ability to get virologic data. So now you have the same youth on a first-line regimen and they have a viral load of 10,000. And they say, doctor, I'm taking my medicine. And you have a judgment call. Are they taking their medicine and they have a resistant virus and they need second line, or are they not taking their medicine and they're not ready to commit? And this is a cost issue as well, because second line is 4 times as expensive. We don't have third line, but that's about 14 times as expensive as first line. And these kids need medicine for their entire life, so you don't want to make the wrong call. So we decided we would test another outcome of adherence, which is more objective. It's taking hair samples, and it gives you a real quantitative measure of if youth are taking their medicine. So the study, again, it's couched out of a former study. Youth were 11 to 24 years of age and attending an already existing HIV-focused clinic. And for this subset, all youth included were receiving antiretroviral therapy, or at least they were prescribed. And for self-report, we had a pretty strict definition. We asked them 2 questions about if they're taking their medicine with some dialogue about forgiveness. It's hard for many people, et cetera. And if youth admitted to missing any medication, we just lumped them in an inadequate adherence category. Then for our objective measure, this is just walking you through a bit of the process. So it's real easy. You need an alcohol swab to clean off your tweezers and your scissors. We want to get a hair sample from the occiput and as close to the root as possible, but we're not using razors, so there's really very little risk of harm or injury. You put the hair, and the idea is 20 to 30 strands of hair is adequate in this foil. So if you're like me, I lose 20 strands of hair probably every 5 minutes. So it's not a lot. And then you pack it up, you put their ID number and the date, and you can really store it for as long as you need. It doesn't need a cold chain or anything, so room temperature is fine. It's not a biologic, so from a shipping standpoint, you don't need dry ice or anything like that. There's no needles involved, so youth like that. And it gives you a longer-term measure of adherence. So the analogy is often in hemoglobin A1C as opposed to a point-of-care stick for glucose. So instead of a how did you take your medicine yesterday, this gives you a window of like weeks to months. So it gives you a much better idea. As part of the study, we also did viral loads. And for those with a viral load of greater than 400 copies per ml, which was our definition of failure, we sent those samples to the Duke Human Vaccine Institute for resistance testing. And then CD4 was extracted from the chart, the time point closest to when the study took place. So it's within 6 months, and also the regimen that the youth was receiving. Statistics are descriptive in nature, and then we also did chi-square for categorical data and Wilcoxon-Rank sum tests for continuous variables, and resistance sequences were analyzed in the Stanford resistance database. So to our results, there's a few I really want to point out. So our total in here was 227, of which 91 had virologic failure. So that's 40%. For those of you who are familiar with the 90-90-90 goals, the goal is that 90% of people receiving antiretroviral therapy be suppressed. So here we're at 60%, and that's pretty true among youth, and this is a big reason why youth are dying of this disease. If you look at virologic suppression versus failure, there was no difference between sites. So KCMC and Mawinzi were about the same. Age was about the same. 16 years of age was the median. More than 90% of these youth are perinatally infected. So they've been living with the disease for 16 plus years. About 50% were female. There was no difference between first or second line. So in an RTI-based regimen is considered first line, PI-based is considered second line. But important to note, 33% of those with virologic failure were receiving second line. There is no third line medication in Tanzania. So if you're failing second line and you get resistance, we have no salvage for you. And unfortunately, we have about 1 case a month where a youth succumbs to this because there's no rescue. And we got to them too late. As we would predict, CD4 was significant, so those who had a lower CD4 were more likely to be in virologic failure. But importantly, one of our study questions, there was no difference between self-reported adherence and virologic outcomes. So we can ask them all we want, but does that actually predict outcomes? And this data suggests no. So for hair drug concentration, what we found was it was highly significant. So the higher the level of your drug concentration in your body, the more likely you were to suppress. This was true for every drug we tested with the exception of atazanavir, but we only had 18 youth in that category. So I think if we had more youth and more power, we would show significance for that drug as well. This is a different way of showing similar data, but it gives you a bit more information in the box and whisker plot. And I think the important things to note here, you can see a pretty strong cutoff. So the middle line going through the box is the median, which is the same information on the last slide, but you can see these outliers. So our resistance data, we were able to analyze about 3/4 of the youth with failure. And for the category of nevirapine, you can see 28 youth were failing, receiving nevirapine. Of those 28, we had data on 16. Of the 16 who we had data on, 94% had high-level resistance. So these youth need to be switched to second line, but they're not being switched to second line clinically. These two outliers above the interquartile range, we don't have resistance data on those 2 points, but I would predict that there was resistance there. For efavirenz, the one outlier, that person had a level of 15.9 and they did have high-level resistance. The 3 who did not have high-level resistance that we had data on had a very low level. So those without resistance basically weren't taking their medicine. So this is a really strong predictor tool, and it really helps the clinician decide, what do we do here? Is it really that they're not adherent, we need to counsel more, or is it really that there's a resistant virus and we need to switch them? For the PIs, for lopinavir, only 1 youth had high-level resistance, and their lopinavir level was actually 1.83. So they were probably intermittently taking their medicine, driving the resistance, but the higher numbers we don't have data on. So whether or not those 3 had high-level resistance, we don't know. For atazanavir, there was no high-level resistance, so it seems to be a robust option, and we had 7 of 8 with resistance data. So in conclusion, virologic failure was rampant with 40%. This poses not only an individual health risk for mortality, but also a public health emergency, because many of these youth are sexually active. You can imagine it's very challenging to disclose your status to others. So there's a real high risk of transmitting resistant virus to others. ART concentration in hair strongly associated with virologic outcomes, and I think it could be a really nice clinical tool in a setting where we don't have resistance data available. And then identifying an ART-specific threshold by which, if a youth had that threshold, then we could feel comfortable that they're taking their medicine, likely they're suppressed barring any resistance. I think that that would also be helpful in making clinical decisions in low resource settings. So again, none of this happens with one person or even one funding mechanism. CFAR was really the seed to all of this that transpired. I'm presenting on behalf of Zachary Tabb, who's the third gentleman from the left in the picture. He was with us on a Fogarty fellowship last year. And just did a tremendous job with all the projects that we gave him. Blandina Mbaga, who is the local PI, who is just fantastic in support and insight into how to make these projects work. Colleen Cunningham, who has been very supportive of me since I started ID fellowship here back in 2010. Elizabeth Turner has been great in helping us with statistics and is going to help us with specificity, sensitivity analyses to determine thresholds. And then Monica Gandhi is at University of California, San Francisco. And she, through her R01 grant, she was able to run these hair samples for us for free and give us a lot of support in analysis. So many people to thank, and I'm happy to take any questions. Yeah, it's a great question. So, so the question was, can youth refuse to have a hair sample taken? And if that were to happen, how can we either encourage them to proceed or do adherence counseling despite having the test done? So this was for research purposes only, but to highlight Julia's point about the CAB, before we offered this, we went to our local CAB and said, this is what we're thinking of doing. And they said, oh my goodness, hair can be a sign of witchcraft, right? And so if you don't really explain what you're doing here, they're gonna think, you're doing really bad things with their hair and they're not gonna go for this. So with the CAB, we determined ways of explaining what we were doing. Very few. I think one person was reluctant, but did in the end give hair, and she had beautiful braids like you, and was very afraid of the aesthetics. So just really reassuring, you're not going to be bald. No one's going to know that we took a bit of your hair. It was much more of an aesthetic reason than any other reason. And then even if someone's perfectly taking their medicine, we still do adherence counseling, especially in youth, because one day to the next day, things change. So adherence counseling is always present no matter what. But for research, they can certainly say, no, I don't want to do that, and we respect those wishes.
Dorothy, thank you for that. I think the hair is very, very interesting. It's like a tree, essentially. But we're doing a little hair stuff here at Duke as well, and I've always been kind of curious if you think this will ever become a viable clinical tool in terms of the price and how long it takes. Because it's taken us something like 3 months working out the hair thing.
Mm-hmm.
So it doesn't seem viable yet. But has Monica kind of described how it will be one day?
So Zach is actually presenting this work at ID Week in October, and this is the topic of conversation. Because for my K award, the Sauti Avijana project upstairs, I have hair data, I have the hair samples, but I'm on a $20,000 K budget, so it runs short. And so looking at ways to fund it, to test these thresholds. But I do think if you can come up with a way that having that threshold means maybe you don't have to always get viral loads and you don't have resistance data, if you can show a cost analysis of decision-making trees and prevention of putting someone on second line or doing so, and how that helps your clinical decision-making, I think it's possible. It would be really nice if it could be done locally, and I don't know how easy that would be to happen. So yeah, I think we'll pick up that conversation in October, because I share the sort of it's great, but how scalable is this? And I don't know the answer, but I think it's worth trying to make it scalable, because I think it's really helpful. Thank you.